Okay, I think it's time for us to get started. Thank you for joining us this afternoon for I think it's our 11th bus stop. Is that right, Joy? Yeah, we've done one a month since the beginning of this year. So thanks for joining us this afternoon. Before I introduce our speakers, I did just want to put a plug into you for December 14th. Garrett's going to conduct an all-staff meeting up in the cafeteria on the 14th. It'll start at 1:30. So hopefully you have that on your calendars and you're planning to join us for that. We're looking forward to that opportunity to talk with everybody. So in case you don't know me, I am Sarah. Garrett is not able to do the introductions today. He's over in Iowa City at an event over there today, so I get to do the honors of introducing our speakers. As we get ready to apply for accreditation, we've spent a lot of time in the past year looking at some of our infrastructure that we have in place and need to have in place to do our work, including governance, legal capacity, vision, and workforce. With this bus stop today, we've decided to highlight the importance of collaboration in the work that we do in public health. Addie and Mary are going to talk with you today about collaboration they've experienced both inside and outside of government. And collaboration, you'll hear, was essential for them to meet their goals with their projects. Mary Green and Addie Rasmussen are community health consultants with the Bureau of Family Health. Since 2012, Mary has been serving as the Abstinence Education Grant Program Coordinator, and Addie has been the Personal Responsibility Education Program Coordinator. Along with their work in teen pregnancy prevention, they both serve as the co-adolescent health coordinators for the Title V Maternal, Child, and Adolescent Program. And this year they've been leading the National Network of State Adolescent Health Coordinators as co-presidents. Also, one of the things we would like you to take out of the session today is that they're going to tell you about aspects of quality culture, including the use of data, the importance of keeping our customers at the forefront of our work, and sharing our results with partners and customers. So thank you for take it away, ladies. Thank you.
All right, well, good afternoon. I'm Mary Green, and I'm going to start off. But thank you guys for coming, taking the time out of your schedules. Please know for Addie and I, it's a pleasure to be here, to be asked to do this. So thank all of you guys for inviting us as well. Before we kind of dive in and really get into this, we're going to a couple of things here. We're going to spend some time really talking to you guys about the power of collaboration. But it comes with challenges, and so we'll be very honest of the things that we kind of struggled with along the way. But we all know it's important in our programs. We know it's important for us to be successful. With limited staff and funds, collaboration seems to be at the utmost importance. So to align with the bus stop, this is a large group, so I'm not sure it makes sense for us to go around and introduce ourselves, but I do want you to know at least somebody who's on the bus with you as we go through this next hour. So if you could just turn to the person next to you, or if there's somebody you don't know, just introduce your name and the program you work in. So there's a lot of you guys I don't know, I haven't seen, so this is great, I think, yeah. Hope you make a good first impression. So to get started though, I'm going to take you back a few years so you can understand a little bit about our story and how we got to where we are today. So a few years ago, our bureau chief at the time had sat Addie and I down and really shared her vision with us about how she wanted the adolescent health infrastructure to be built up. You know, she says we do an incredible job with our early childhood, but we need to do better with adolescent health. So Addie and I were still pretty green to the department. I mean, we had been here about a year, finally had a grasp on our own grants and got to know our contractors, and now we had this new directive, and it doesn't come with the PDQ, doesn't come with any extra money or guidance, and that can be scary for a deep, I like tasks, and this, so it was new for me. But we just kind of looked at each other and said, we don't know what to do, but we're going to do something. So that's where we started. So our first step was we reached out to the State Adolescent Health Resource Center. If you're not familiar with them, they are located within the Kanopka Institute at the University of Minnesota. Thank you. But their primary role is really to provide technical assistance and training to state maternal child health professionals to equip them so they can run their programs better, so they're trained in adolescent development, ultimately improving the lives of Iowa's adolescents. So we reached out to them and then had multiple conversations with them. We learned from them. We were like little sponges. We wanted resources for them. That was our first step. Our second step was reaching out to other states, sending emails, introducing ourselves, and really just, we want to know what your state looks like. You know, how are you funded? What does the structure look like? So we spent a considerable amount of time talking to some other states. Externally, that's where we started, and people noticed that. People noticed that, okay, we have these two people in Iowa who keep talking to us, and they want to move the needle, they want to do something. And then we started getting invited to some really cool things. So then a couple years ago, University of Minnesota called us along with 6 other states and said, let's talk about the possibility of developing a comprehensive adolescent health system. You know, can we realistically do that? And like she said, who would have thought we would ever be president-elects and now president of a national network for state adolescent health coordinators? But that's because of the partnerships. That's because of the collaboration and putting ourselves out there. So externally, that's where we started. Internally then, again, shifting back a couple years when we got this new directive, was we really just started talking to some program staff that said, you know, there seems to be a lot of programs that touch adolescents. Are we talking to each other? Do we come together often? And realized that collaboration might have been a little bit more minimal at that time. And so we thought it was just an opportunity to maybe come together more often, maybe collaborate in more ways. Other reasons that we wanted to do that though also was, again, with limited staff, limited funds, we had to ensure we weren't duplicating efforts. That was one of the reasons for collaboration. Other one was really just to build cohesiveness. So we knew the people within our department, so we felt comfortable when reaching out to them. So when my contractors or a customer approached me that says, I need data from someone, I knew how to get it without kind of chasing my tail and asking around. So those were a couple of other directions that we wanted to ensure that we were achieving. So what we did, again, we didn't know what to do. We sent a message out via the internet, inviting people, anybody who works with adolescents, anybody who oversees programming, would you be interested in coming to a meeting? Brought them together for a meeting, and we just discussed the possibility of, if we could collaborate more, what would it look like? And as a result of that meeting, the Adolescent Health Collaborative was born. And so 2 of them are in here, part of our collaborative, but I'm just gonna share with you who they are. So starting with tobacco use, that is Robin Dutchow. Julie Hibben with substance abuse. Janice Edmonds-Wells with minority and multicultural health. Maggie Ferguson with brain injury. Tiffany Conroy, she's pretty new. Benny LaHue, they are both with domestic violence. Pat McGovern is with suicide prevention. And Elisa Pearson with EPSDT and child health. Jean Johnson with children's health insurance. There's Addie and I with teen pregnancy prevention and adolescent health. Kelly, who's with us here today, Rooney Kozak is with immunizations. George Walton with HIV, STD, and hepatitis. And Denise Wheeler with family planning. So that makes up our collaborative. So what does it look like? Well, what we started doing was coming together on a bi-monthly or quarterly basis. And you'll see there, in 2014, we had 8 meetings throughout that year. And we spent the better part of that year, program staff, just educating us on what their programs were, what were the counties that they were reaching, are we doing any overlap. It was really a year of complete education, ensuring that we knew the foundation of who's touching adolescent health within the Iowa Department of Public Health. Then you'll see in 2015 there was 5 meetings. 2016, we've had 4 meetings, so it starts to dwindle a little bit. And I'll go into that. We come together, we talk about agenda items. Other ways we've collaborated, to give you some ideas, is Addie and I have really capitalized on some of our members within the collaborative. So when we have our annual grantee meeting for all of our teen pregnancy prevention contractors, we've invited them in So we had Julie Hibben come, and she talked about substance abuse in adolescents and what the current data is, what are the new trends, what do they need to do so that they can be more effective in the field. Same thing, we did that with George Walton with STD, HIV prevention. Again, data, trends, what do you need to know? Because you work in a teen pregnancy prevention, but adolescent health broadly, all of those topics touch our young people. And so we really use those to equip our own contractors. The other ways we've done it is now it's really second nature to us. So if I'm exhibiting at a conference, I reach out to the collaborative. If you guys can't be there, do you want materials on our table? And we do a very good job at that because it's just a way to reduce staff time and still get program information out to people. The last thing we worked on here recently was Healthy Iowans, talking about adolescents and a preventative well visit. So those were some of the other things that we had worked on. But with all of this is great. We've met people, we've learned a lot, but it doesn't come without its challenges. The logistics alone of getting a group of people that size together bi-monthly or quarterly is very difficult. The other thing that is very hard is everybody's time is incredibly busy. So if you're not coming together maybe for a specific project or a grant that you're working on, so if you're not at that meeting, you all kind of know that Kelly's not at the meeting, competing priorities take place, and that's understandable. So we've struggled with that a little bit about having full attendance at our meetings. Okay, so that brings me to a couple of things. If you're not familiar with AMCHIP, the Association for Maternal and Child Health Programs, they came out with a request for applications a couple years ago. And this is a mouthful, but it was Life Course Indicators Intensive TA Project. And after we read the guidance though, we were super excited because now we had a program, now we had a project that could involve our collaborative. And in fact, it just didn't involve them, we needed them. We needed them to make this project successful. And that's where it's going to start a little bit with our journey. The one thing I didn't mention on the previous slide, that something that we would like to do more of, that I think we can do better of, is that Addie and I, as we were preparing about this, talked about, if there was like a headline that came out in the paper in regards to adolescent health, it would be nice to get like an emergency meeting or pull the group together to address that. And an example of what I mean by that is CDC came out with a report here recently that in 2014, the suicide rates for youth ages 10 to 14 now match that of the same age group with traffic accidents. So our young people are dying at the same rate of suicide as they are traffic accidents. In an ideal world, it would have been, let's get this group together and let's talk about this. Should we do something about it? And can we do something about it? So we're not there, but always something to strive for, right? So back to the project, and this is where Addie's going to take off, and this is where the story kind of starts. So now we have a project, adolescent health, and now it's going to involve our collaborative. Great.
So we hand the mic off now, so that's kind of
This
the
is
big
new
thing.
to
So
us, and the camera.
people should not give us microphones very often.
That's true. Okay.
So I'm going to talk a little bit about life course theory. So who in here is familiar with life course theory? Anyone? Anyone? Do you guys want to come up here and talk a little bit about it? No? No? Not so much? I'm not an expert on life course theory, I will have to say that. But this is kind of the basis for the project that we were working on. So life course theory is very much a conceptual framework. And this is something that really helps explain life and disease patterns, particularly health disparities across populations and over time. So as you'll kind of see, we love the models that come together with public health, and that's something that we really use. But life course theory really points to more the broad social, economic, and environmental factors as underlying causes of some of the inequalities in health. And life course theory is very much population focused, and so it's firmly rooted in the social determinants and social equity models. So it's just another way of kind of describing things that are going on with health. And though often, not often explicitly stated, it is community or place focused. So it very much, the social, economic, and environmental patterns are closely linked to a lot of the communities and neighborhoods where we live and where we work and where we play. So just in short, it's a broader way of looking at health and the many factors that interact together to kind of shape our health behaviors and our health outcomes. So it's to say that the things that happen to us, the behaviors and factors that happen in childhood and adolescence are going to have an impact on us as we get older and across the lifespan. So the risk and protective factors that come into play throughout your lifetime do have an impact as well. So a little bit about life course theory, and this is AMCHIP, like Mary had said, the Association for Maternal and Child Health Programs, is very much deeply rooted in this life course theory, and they have kind of taken this on, and they really wanted to identify a set of indicators to measure it, right? We have to have measures to see where we are with some of these theories. And so the first project that they did was to identify these set indicators that were related to life course that would cover the entire lifespan. And our Bureau has been a part of that and has been very much involved since the beginning. So some of our colleagues, Debbie Kane and Kim Piper, if you guys know them, are a couple of our colleagues within the Bureau. They were part of the representatives that came together in this first cadre of states to really identify these indicators. So what they did is they started with a list of 413 proposed indicators. Like 413, that is a lot to measure life course theory. And what they did is they narrowed that down to 59 indicators. And those are categorized into 12 categories. Those are in the gray circles that you can see up on the screen. So everything from social capital to discrimination and segregation, economic experiences, mental health, etc. And then there's a couple of examples of the indicators that are included on there. I didn't want to put all 59 to overwhelm you guys, but those are just to give you a little bit of taste of what those are. So while there's substantial and growing literature and research on the life course theory, the translation of that theory in research into practice is far less developed. And if it is, it's been done with more of the, within MCH, the moms and with the babies. And that's we do a really good job, like Mary said, with early childhood, and with those moms we do a really good job, but the adolescent health, we haven't really been doing a whole lot. So the goal of this AMCHIP TA project, when they came out with it, was to address challenges to state health departments using the life course indicators in their work and encouraging projects to incorporate the theory into practice. And we saw that and we're like, you know what? It'd be great. Like maybe we could do something on adolescent health because we don't really do that all that often. Like they've been using these life course theory within early childhood and some of the prenatal care that was going on. And as Mary mentioned, the announcement came out at that time when our collaborative was like, you know, what are we doing? Where are we going? You know, things are dwindling a little bit. So we're like, you know what? We'll submit an application and see if it's chosen. Well, we were chosen, so that's why we're sitting here today. So we were one of 8 states that were selected to participate in this first round of the project. Since then, they've had another cohort go through, and it's something that they're continuing on with. But I will say that this was a very quick project. It was a 6-month project. That's very, very fast as some of these happen. And even to finish something in 6 months is a lot. But the main goal was that states were to create a deliverable. You had to create something in that 6 months that was using the life course indicators and then be able to give that out to a population that might not be familiar with life course. So it's really getting awareness about life course health, but we also wanted to get awareness of adolescent health out to people. So in our application, we had said that we were going to create something for adolescent health providers. And as we came together with a collaborative when we were chosen and we started having conversations about it, we're like, you know what? We really don't have a relationship with the adolescent health providers in the state. Granted, they're only like a handful or less that actually focus on adolescents, but even the physicians, we don't have that relationship yet with that clinical side. So as we started talking about it, one thing that came up with was school nurses. So middle school and high school nurses, some of us have been going to the conferences that they have every year. They host a couple conferences. They've always been very receptive to the information that we have to give them. They want to talk, they want to grab our posters, our things. So we thought that might be an avenue. And we work we've developed a relationship with Melissa Walker. She's the school nurse consultant over at the Department of Education. Is anyone familiar with her? Yeah, people have heard her name. So she's great. We've talked with her, we'd had meetings with her before, and I think that really helped us with it. And she maintains a listserv. So the listserv goes out to all the school nurses in the state, and so information can be sent out to them. So we kind of approached her and asked her a little bit about it, and she assured us that this population would be great. To do a project around adolescent health with the life course indicators would be great, that they're always hungry for more information, they're a very captive audience, etc. And she thought it would be a great way to increase adolescent health within the school nurses because they're really, they're spread pretty thin across the state. There's not a lot of them, and if they focus on things, they focus very much on that early childhood, or they're with those elementary, maybe into some middle school. So that was something as well. So that leads us to our first pop quiz of the day. So it's like you're kind of in school, right? Does anyone know how many school districts are in Iowa? This is public school districts.
350.
350?
250.
Did you see this before? That's pretty good. So, yeah, so there's 357 public schools. The listserv maintains over 800 school nurses. As I said, I think the ratio right now is there should be, or the recommendation is one school nurse for every 750 students, which there's no way that one school nurse for 750 students. There's many school districts that only have one, and they're maybe only, they might be part-time, not even full-time. So, and again, they're probably more at the elementary school. So we wanted to equip them with some more information and materials that they could have to address and talk to the middle school and high schoolers. So kind of that 10 to 18 age range. So that was one of our goals with that. So after we had identified the school nurses as our target audience, our goal was to create an interactive resource for them, because as I said, we had to have a deliverable. So we wanted to do an interactive resource that really would give them a snapshot of how Iowa's adolescent population is doing without it being too data heavy. Because honestly, I'm not, love data, but just give me a little bit of it and I'm good. You know, I just need to know some of the basics. And they have a lot of students in there, they have a lot of other things on their plate, so we wanted that for them to really just kind of take that in. And we also hope that this awareness would permeate throughout the department and with other agencies and or stakeholders that we were working with. Not only the life course theory, but also adolescent health. So it's something that, as Mary said, we were trying to work on to really kind of build up within the state, but also here within the department. Bringing life course theory to our collaborative, some of them learned a little bit more about it, and were able to kind of talk a little bit more freely about it, knew what the indicators were. And we realized that a lot of the indicators that members of our collaborative were using were some of the same indicators that were included on the life course theory. So we're going to kind of go into those indicators now, but what can you imagine if we were trying to paint a picture of the adolescent population and think of the people that are on the collaborative? What do you think some of the indicators were that we included in this tool?
Tobacco use.
Tobacco use, yep.
Alcohol use.
Alcohol use.
Obesity.
Suicide, mental health, yep.
STD rates.
STDs, yep.
Pregnancy.
Teen pregnancy, absolutely, you guys are nailing it. So what we did, these are a list of the indicators that were chosen. And so the core project, and I mean the core project team, me, Mary, and then there was another woman within our bureau who was doing a lot of the data for us. She has now since gone on to another position, but she was a fellow here. So we really whittled down that list of 59 to something that was a little bit more manageable to take to our collaborative. So anything that we thought that adolescents, or that would impact adolescents, we brought to them. And so through the collaborative, we then talked through them, and we narrowed it down to this list. One of the conversations that we had within our collaborative was the notion of focusing upstream. So you'll see that teen births and repeat teen births are crossed out. We decided we wanted early sexual intercourse to be that reproductive health indicator, because that's something, again, focusing upstream and a little bit more preventive. We didn't need 3 of them, we wanted 1 of them. And again, Suicide is also one of the indicators, but we decided to use the depression one for mental health because, again, that's kind of doing more of the focusing at straight and not having it too data heavy. So you'll see it says like LC23, that just means life course, that's the number of the indicator that it was. The only one that wasn't included on the life course, it's not an indicator, but we thought it was important to include is the last one. Anyone know why bullying, we would include that? It's a new national performance measure for Title V, so kind of within the work that we're doing with maternal and child health. And the governor has indicated it as one of the things that he really wants to address bullying within the state. And so we thought, if the governor is saying that, we should probably be including it on this tool as well because it's going around throughout the state. So, for those of you, I know that there's some data people in here, you guys love the data. So here are the indicators, the data sources that they are from, and then we're able to do some comparison, whether it's our own comparison within the state or the national average, and then the years that we were able to pull some of the data from. So with the life course metrics, this was the Life Course Theories National. They wanted to use national data sources, whereas here in the state, you see a lot of them are coming from the Youth Risk Behavior Surveillance System. Here in the state, we also have a complementary survey. It's called the Iowa Youth Survey, and that goes out in opposite years of the YRBS. And the IYS is great because it can get to county level data, whereas YRBS is only statewide data. And we'll have to say it's kind of been a struggle because the last couple of years of the YRBS, we've not had enough participation to get weighted data. So the last year of weighted data is 2011. So it was really hard. We talked about it in the collaborative and as a core team, like, do we use IYS data or do we use YRBS? And for the purposes of the project, since it was ANCHIP, we decided to go with the YRBS. But we knew that that was kind of a caveat and a limitation that we were going to have to address, where some school nurses would want to have that local data. But we figured we could maybe get that out to them in a different capacity. So. Those are the indicators that were chosen. And before we then move on to show you this tool, because it was this tool that we had to create, I want to know if you guys have an idea of what our adolescent population looks like. So we're going to do another little pop quiz on all of these indicators. So what we're going to do is for each of the indicators that were included on that list, I'm going to ask you whether you think Iowa is improving or better than the national average. So you're going to give me a thumbs up for that. If we're remaining stagnant, there's little or no change. So I'm calling it like the mid-level mid-thumb. I don't know what you call it. Or then if we're getting worse or our rates are worse than the national average, so then just give me a thumbs down. So we're just going to go through them and see how well you do. Kind of gauge yourself on how well you know Iowa's adolescent population. And I don't know, do you guys have any teens? Anyone here? I mean, you can think of them, or just think of the broader population. I'm going to think of Mary's kids when we do this. So that's who I immediately go to. So the first one, childhood screening. So the indicator for this, or the data point, was the percent of Medicaid enrolled children in Iowa who receive at least one initial or periodic screen in the past calendar year. So do you think Iowa's been improving, like remaining stagnant, or do you think our rates are getting worse? What do you think? Okay, so we're actually remaining stagnant with this one. So there is some room that we can be getting a little bit better with that. The next indicator, the data point, is the percent of 9th through 12th graders who reported having been bullied on school property or electronically bullied in the last 12 months. What do you think? Do you think that we're better than the national average, about the same, or worse than the national average? We are worse than the national average in both instances. So our rates are higher than the national average. So that was a little eye-opening to us as we think, I was pretty good with that, but no, we have some room. Depression, this was percent of 9th through 12th graders who felt sad or hopeless almost every day for almost 2 weeks. What do you think? Do you think we're improving year to year, about the same, or decreasing? I see, yeah. We're kind of remain stagnant. So you can see we're below the national average, but our trend is remaining consistent throughout. The data point for this one is the percent of 9th through 12th graders who reported initiating sexual intercourse before age 13. Do you think we're improving, about the same, or getting worse? So we're actually remaining stagnant. Although teen birth rates have been going down and we've been doing a really good job, this is again that preventive measure where we're going back to that kind of focusing upstream and how we're doing. So again, we're below the national average, but again, not much change. Percent of adolescents, males and females aged 13 to 17 who received the complete series of the HPV vaccination. What do you guys think? Think we're improving, no change, or is it decreasing? We are increasing, which is great. Something we're doing good at. This is percent of persons ages 12 to 25 who reported illicit drug use in the past month. Do you think Iowa's rates are better than the national average, about the same, or worse? Okay, so we are actually below the Midwest and national average, which is a good thing because we want low numbers for that. So it's kind of that net double negative, but we're doing a pretty good job in that instance. Obesity. This is percent of children 10 to 17 years who are overweight or obese. Do you think we're improving upon this indicator, no change, or getting worse? We are getting worse. So although we're below the national average, our rates are going up, so there are more who are overweight or obese in that 10 to 17 age range. Oral health, percent of children with a preventive dental visit in the past year. What do you think? We're doing good? No change? Bad. We're doing above the national average, which is great. Physical activity, percent of 9th through 12th graders who were not physically active at least 60 minutes per day for at least 5 days or more in a week. Do you think Iowa's improving? About the same? No. Actually improving. So it's against that double negative. Our percentage is decreased, meaning more youth were physically active in 2011 as opposed to 2007. And again, we're going back to those years because those are the last years of the weighted data. Smoking. How do you think we're doing? The trend is up, doing good, not good. Actually doing well, our numbers are going down for smoking, which is great. Violence and abuse, so percent of 9th through 12th graders who were ever physically forced to have sexual intercourse when they did not want to. Do you think I was improving on that? No change, or we're getting worse? Although we're better than the national average, it's been not much change. There was a little bit of a dip, but then it was up again, so not a whole lot of change with that one. And then this is our last one. Oh, and I just gave it to you. Just gave it to you. So this is the percent of 9th through 12th graders who've had at least one drink of alcohol in the past 30 days. So the percentage of youth reporting drinking has decreased. And in the previous session, they thought that was on the rise. So this is good that, you know, our numbers are looking better with that. So how do you guys do? Okay? Yeah. Feel like you know our adolescents a little bit better? You know, maybe kind of where they're at? So this is just a quick snapshot of the indicators and kind of how our youth are doing. And so we wanted to pass some of the same information along to school nurses in an easy to understand manner, kind of like we were doing. So this will be a time where we're going to pull up the interactive tool. So Mary's going to pull that up for you. We're going to talk about it. So for our communications product, we wanted something that was easily accessible on computers, laptops, or other devices for school nurses. We know that they're busy during the day, and something that could just be pulled up really easily. So what was created was an interactive PDF. So this literally is just a PDF file. And we had one of our colleagues within the Bureau who does some graphic design for us. She was the one who kind of created it as we pulled all of it together. So as you can kind of see the face page, it looks kind of similar to what we just did, doesn't it? So we'll kind of walk through each of the little sections. So you'll see that each of the 12 indicators that we've talked about are in an arrow right there up at the top. And they are color-coded for a reason. They're indicative of how we're doing. So it's just like we talked about. So as you can kind of look at that, you can see the ones in green, we're actually doing a pretty good job with. The ones in yellow, we might need to start addressing this a little bit, and those in red, we really need to, you know, be helping our adolescents really get these rates under control. So when you look at those indicators, what you can do, and Mary, our lovely assistant, and will be showing, if you hover the mouse over one of those indicators, a little box comes up. And a little box of talking points. So these are talking points that were specifically created for school nurses that they can start talking to an adolescent about. If they don't know how to bring up a conversation or how to talk about some of these, this is a really easy way for them to do that. So you can do that for each of the indicators, and then also at the bottom right are some directions and helpful tips for using the tool. We knew we were not going to be able to get out and talk to all of the school nurses one-on-one to tell them how to do it, so just to have some directions right there was something that was really important. And the last thing that I want to say about this face page is that we were really bridging together public health and education with this project. So we wanted to show that there is a place for public health within the education sector. And so as you can see, that all of those indicators are an important thing of an adolescent's life. And if those things are not being met for the adolescent population, they're going to have a hard time sitting in that class and learning the different things. And although we know that in public health, sometimes the education department doesn't really understand that. It's really kind of focusing on the benchmarks they have to get to. And, there could be an adolescent in there that, hasn't had breakfast and, could have, parents are having fights at home or, is dealing with some depression. And, there's other things that are going on that they would need to look at. So that was something that we wanted to really focus on and really tie that together with the life course. So say a nurse has that up, they might have a little bit more time with an adolescent or just a little bit more time in general. So what they can do is they can click on any one of those indicators. So we're going to go and start with bullying. And what comes up is a full fact sheet. So this fact sheet comes up and they all follow a very similar format. So you see the life course indicator, the data right there, the state and national data showing nurses how Iowa compares to the US or how we're doing. There's an infographic on each of the pages to go along with that data piece. The original talking points with that hover over come up in the green box. There's also a yellow box with supplemental information, so other things we thought that they should know. Whether there's current trends or initiatives going on. For the illicit drug use one, there's a lot of the slang terms that are on there that nurses could be aware of or might not know. And then the box in the bottom right-hand corner, the blue one, is some additional resources. So it's hyperlinked, there's a few of them there. Not only resources for nurses to use, but ones that they could pass along to parents, to other school administrators, and even to youth. So that box is pretty small, and so we relied heavily on our Adolescent Health Collaborative to provide this information. So as you see, a lot of those indicators linked up really well with the people that were sitting around the table. And so we could just say, hey, can you get us some information and some resources? So we were able to use that and bring that together. Melissa Walker, the school nurse, or at the Department of Ed, she helped a lot with the talking points. She has been a school nurse. She knows kind of that setting, and she was able to really help us craft and make sure that we had the most important things for those talking points that would be pertinent for the school nurses around Iowa. So then at the bottom, there is a go back to the home page that they can click on, and then we'll just show you another one, Mary, if you want to bring up alcohol use. And then you can kind of see that it follows another, again, a very similar format in how that's being brought up. So that's a little bit about the tool. So any questions about that? So again, you can see the boxes sometimes come up. This was just used with a PDF. I think it was created using Adobe InDesign, so that it's layered on top of one another. I don't really understand the whole thing. Our graphic designer does. But it was a great thing and something that could be sent out via the listserv. So right after the tool was created, we decided to pilot it in the spring of 2015 with several middle school and high school nurses in the Des Moines area. As much as we would have loved to included the school nurses in the whole process and conception of all of this and building it, we didn't have that time. We had 6 months, so we wanted to pilot with them. So what we did is we went around and we met with some of them. We asked them, we talked to them about the project, we showed them the tool, and we said, you know what, use it for a couple months, or use it for a month till the end of the school year, and then we're going to come back and get some feedback from you guys. And they were more than willing to do that. And the feedback that we got was that they thought this was a very valuable tool. Something that they used, it was effective in engaging adolescents, but they also said it was great to bring in the guidance counselor. It was something that they could share with school administrators and with parents. So that was a positive and something that we hadn't really expected. The other thing was is that we heard that there were some additional topics that they wanted to talk about. Although we could cover anything. I mean, the things that school nurses have to deal with is you know, all across the board. But one of the things that we kept hearing was cutting. Cutting was another big thing, again, related to that mental health. Anxiety is on the rise, especially within that middle school population, and hygiene, especially with the middle school population. They said sometimes it's hard to bring up conversations with youth when you've never seen them before, you know? And how do you talk to them about hygiene habits when, you know, you have 750 kids and you have no idea who this person is? So we thought that was really good, and the feedback that we got then led us to decide that we could send this out to the nurses. So we spread this out throughout the state then that next year, but right before school got out in May of 2015, we wanted to ask school nurses in kind of getting a baseline, you know, how often are they talking to adolescents? You know, are they comfortable talking to adolescents? Do they have resources available? And that was gonna kind of help us determine, you know, what we wanted to do with the tool and how we were gonna, I mean, we can send the tool out and then we're done with our 6-month project, you know? We have that and we can send it out, but what are they experiencing? So we got some of those back, and we asked them about the frequency with which they are talking to adolescents about these topics, and these are the exact same indicators. So what are topics do you think that they might not be talking about as much, just because? Which one? Childhood screening, okay. Any others that you think like, I don't know if they're really talking? Violence and abuse, early sexual intercourse. So from a sample of about 170, we had about 170 that filled out this the first time. A quarter or more said that they never talked about the following topics. There's not very many that came off that list. There's still a lot that are on there and things that are really important, right? So we then asked how comfortable they were talking about these topics, thinking that there was maybe a link between their comfort level. And we didn't really see anything. The only thing was that about 10% said that they didn't feel comfortable talking about early sexual intercourse. So it's like, okay, well that's not quite there. But then we also asked about resources. We're like, do you feel like you have enough resources? And of the topics listed above, the only one they felt they had resources for was childhood screening. So that's kind of where that connection was. They had resources, they just needed more, and they wanted more information. So that's where they were wanting more information, and the school nurse consultant was right. I mean, that was something that they were craving, and they needed a little bit more. So the next question was, like, how are we going to engage them? What are we going to do? So and that's where Mary's going to take it off to talk about the next section.
Okay, so, hear me okay back there? Okay. So, as Addie said, we launched this, so about a year ago, September 2015, this tool went across the listserv to all school nurses in Iowa. And then what we did is we put theory into action. So we took those indicators and we turned it into a webinar series. So what you see up there was our schedule of the webinars that we provided. There was 12 indicators, but we wanted to do the webinar series over the 9-month academic calendar. So there's a couple of indicators where we did had to pair those up a little bit. And we also tried to, if there was an awareness month or a national observance, we tried to align that subject with one of our indicators. So just kind of something for you guys to look at. Each month we sent out a flyer via the listserv, always promoting the next webinar. The webinars followed the same format, and so kind of the way it looked was Addie and I would always give the introduction, always referring back to the life course theory. The project expert who was going to facilitate the presentation did the majority of the webinar, and then Melissa Walker came in at each and every webinar and summed it up as far as, okay, with this information, you know, what does this mean, school nurses, for your job? You know, how can you use that in your daily work?
Was there any theory for your topics of picking a certain month, or you just list them out and went with it?
We tried, again, if there was like a national observance day or month, we would do that. We did, with the childhood screening immunization, we wanted to do that close to the beginning of the school year. the other thing was when we could get a presenter, you know, when we could line that up as well. So those are the three primary things, how we did that. Yeah, so then after Melissa, she would kind of sum that up for us at the end. Like Addie said on that tool, you know, there might have been like a space for 3 or 4 resources. So the webinar allowed us to put an abundance of resources at the very end of the webinar. So that was another way we were able to give them some more information. And then we were lucky enough to partner with the Iowa School Nurse Organization. So we were able to offer CEUs for those school nurses that wanted to. And with that came some rules. I mean, the webinars had to be 60 minutes in length. And they had to attend that webinar live if they were going to apply for those CEUs. All of the webinars were recorded. They are now posted on the DOE's website on the school nurse consultant location.
What type of day did you do it? Because
Oh, yeah, I mean,
that's been a problem that we've been heard about when we're trying to reach the school nurses.
Yeah, so you're right in line. That was one of our challenges. Trying to find a time that worked for school nurses across the state was not feasible. So we really took DOE's input, however they guided us, and they said, you know, probably especially Polk County, they get out early on Wednesdays, so let's do it on a Wednesday from 2:30 to 3:30. So, you know, the recordings helped with that a little bit. They could go back and access it, but yeah, they did miss out on CEUs if that was something they wanted to do. So that was, yeah, Kathy, definitely a challenge for us. Okay, so what was our reach? You know, how did this webinar help us reach some school nurses? So on average, 74 nurses registered with an average of 44 attending each month. Our highest one was the very first one that we did with a high of 102 registered and 71 attending. And then as you can see from the map, what we're trying to show is we reached 69 of the 99 counties. So at least one school nurse in that county attended that webinar live. You go out to the recordings, I mean, we can see how many views we get, but we don't know where those are coming from. So we can't realistically say if we've reached more counties through the recordings or not.
Or if they repeat it, you
Right,
can't tell
yeah.
that either, can
Right.
you?
Yeah. Okay, so like, that was one of my things I was going to talk about, the challenges, like what Kathy said, finding the time. And the reality is, it takes a lot of time to arrange webinars. It really does, setting them up, getting your speakers, solidifying those, aligning with a time that works for the Department of Education. So the webinars were great. We can look back and say, yeah, it was worth doing it, but it was tough at times to pull it off, but glad we did. Okay, so with public health, we're always doing some sort of evaluation. So we just really wanted to know, did the webinar series have any impact, and how can we really measure that? So kind of similar to the questions that Addie had asked earlier was, what was the impact on the frequency of the school nurse having conversations with their young people? Okay. And so we had found, the way the question was answered, they could say less, equal to, or it increased. So everyone responds that their frequency, it either didn't change or it increased, if that makes sense. So we took that as a positive because it didn't decrease at all. And then we wanted to find out, did their comfort level through the webinar series, did it make it easier for these to have some tough conversations? And same to this one, increased, their comfort level increased, but also I wanted to point out the subjects that it notably increased was childhood screening and HPV, bullying, depression, tobacco use, alcohol use, and of course, early sexual intercourse. So good to see. And then the last one was, did the webinar provide enough resources to help them better equip themselves in the work they do? Because that was something that they really kept hammering on us with. And so what we found after taking a survey was 97% indicated that the webinar provided them with the resources they needed to have those tough conversations. So some good information that we got. Okay, so any idea, I know we all kind of do budgets. We're kind of familiar with that. Any idea what it cost or what grant funds we were given to pull this off? 6-month project. Okay.
50,000.
50,000, okay. So the answer is 0. We didn't get any funds to do it.
Kidding. You're talking about the webinar program?
The whole
Or the
project.
whole
project?
The whole project.
Nothing.
Nothing was funded from it.
Wow.
That's why we had to have our partners. I mean, seriously, we owe them a lot. We really came together to kick this off, and hence the collaboration is what really made this successful for us. Like Addie said, it's a PDF. Didn't have any money, for any fancy software, but it met the needs for what we needed, so it worked. And again, you guys, it's all about collaboration. The collaborative couldn't have done it without them. Couldn't have done it without the Department of Education. We couldn't have done it without the Iowa School Nurse Organization. And really to drive this home, okay, so there's 9 webinars and Addie and I presented on 1. So we did the intro at each one, we did the ending, we did the logistics.
We
but
were there.
But it
We were
was
there.
our partners that said, yeah, we're gonna do this, and came together and did that for us. So, kind of just shows that. And then we saw this and we really liked this. So instead of thinking outside of the box, get rid of the box, I think again, our project, that's what we had to do. I mean, we had no money and we couldn't do it alone, so we had to really step outside of our comfort zone. And we're getting close to the end of this time, so I mean, you really listened to Addie and I for about the last 45 minutes, talking about this, but I want to bring it full circle and really talk about how it aligns with the department's vision of creating a culture of quality improvement. So to do that, we were very intent about using data to drive our decisions. School nurses, our customers, they were able to provide input and provide feedback. Subject matter experts from a variety of programs addressing adolescent health provided their input. We took the project a step further by doing the webinar series. Once we created the tool, we met the requirements of the funders, but it was our customer that said we needed more. So hence the webinar series came about. And again, the reality is it's not part of our job description. It was a lot of work. It was tough to get through, but 2 years later we're still talking about it. So it's just our way of encouraging you that it can be really scary and hairy and tough at times, but hopefully ultimately the product is worth it at the end. Any questions before we start to wrap it up? Or anything anybody's doing in regards to collaboration that the group should know about?
So if you hadn't had that collaboration, would you have even looked at that project?
No, probably not. It would have been, it probably would have been within our bureau, it would have been someone doing something on early
Something else.
childhood or like prenatal care. But they kind of came to us, and within our bureau, it's like, well, we've kind of done stuff with this, maybe, we should focus on adolescents and.
Yeah. Yeah. Anything else?
And obviously it was helpful to have the collaboration beforehand and not at the beginning of the 6th month and say, all of a sudden have to pull everyone together to talk about it. But because you already had those relationships
Right.
and had those discussions, then it was easy to move into that.
Yeah, I couldn't have said that any better. I mean, it was just without those relationships and that comfort level of Addie and I really saying, we need you really to kick this off and to have them willing to do that.
Do you have plans to update it, either with the topics that the school nurses recommended or with emerging issues or anything else you've identified?
That would be ideal, if finding the time, because like Addie had said, the school nurses, every single one that we visited said, we have a problem with our 5th and 6th graders. Our anxiety is through the roof and we don't know what to do. Every single one of them. So there's a lot of work to be done. It's a matter of Addie and I trying to manage that with our other programs.
They've talked about doing it with guidance counselors, like doing something for them. We don't really have the relationship with the guidance counselors, although the school nurses would have that and could kind of bridge that. So that might be something that we could do. They've even talked about, and Mary mentioned this earlier in the other group, is some of the school nurses had taken some of this information into some of the classes that they were doing. And so we could maybe do some lesson plans around some of this. I mean, there's a really, set curriculum with some of these different topics and, them talking to middle schoolers about this, about bullying, what should they do. But they've been taking some of this in there, so that's another step, possibly.
And this kind of goes along with the, are you gonna do any additional or update it? Because the data that was shown on each of the clips also is, okay, is it making an improvement or not?
Right.
And that's the other thing is, so there was any evaluation on what the impact was on adolescents.
I think we need an intern. I mean, that would be
It's true.
ideal.
I
It's like
like
a
internships, I'll get you one.
it's like a project for them to do that, and we've talked about how often do we do this, when is that gonna be, the information in the webinars though is very pertinent, and a lot of the data that was then presented, they could give, I will use survey data, they could give more updated data as well, so I think that we'd be okay for a year or two, but then again, having that opportunity for school nurses to then, have some more CEUs again with the live webinars would be great, so. If anyone wants to help us with that or present, we would gladly take them.
I just want to applaud you guys for all that you've done with adolescent health, because I know, the way that the majority of us are funded is through a grant, either one grant or multiple grants, pay our salary and the work that we do. There's no grant for adolescent health, so there's no money to do any of this work. You have your teen pregnancy prevention grants, that's your primary focus, and the fact that you've been able to go so far above and beyond to address all this additional issues with adult health is really amazing. So
Thank you.
Lindsay, I appreciate that. Vicki, anything you want to say on this, or just as a reminder, like Sarah had said, there's not a bus stop this December because of the all-staff meeting?
No, but we will reconvene bus stops starting in January. In January, it is on emergency operations, and our Bureau of Emergency and Trauma Services will be highlighted. So, and then come to the all-staff meeting in December. Thank you guys, excellent presentation.